Welcome everyone to Asking for a Friend, MHPAEA edition. Thank you all so much for joining us. Our speakers will be answering the questions you send through the Q&A today. We will try our best to answer all of your questions, but if for whatever reason we're unable to get to your question today, please follow up with your advisor for further assistance. Today's presentation is being recorded. We will be sharing the recording in the follow-up email and on the NFP website. If there are any portions of this call that you missed, by Monday, you'll receive an email with a link to the full recording. The PowerPoint slides used during this presentation will be shared in the same email. At this time, I'll hand it over to Sarah Burns, Vice President and Counsel of Benefits Compliance at NFP, and Sharon Cohen, Vice President and Counsel of Benefits Compliance at NFP. Sarah, the floor is yours.
Thanks, Amber, and welcome everyone to our August GetWise Wednesday Asking for a Friend MHPAEA edition. Sharon and I are really pleased to be here today to talk to you about MHPAEA, which is an acronym for the Mental Health Parity Addiction Equity Act. It's kind of a fun acronym for a complicated law. Before we get into our agenda today, Sharon, can you hit the next slide, please? We need to remind you all that our NFP's benefits compliance team, we can't give tax or legal advice. And also that the information in today's webinar is current as of August 20th. I know that today is the 21st, but I say August 20th because these rules, especially these MHPAEA rules, are in flux, which we'll talk about later, and they could change any minute now. So we have that date there as August 20th. If we get any updates while we're on here live today, we will try to share them with you, but we can only guarantee the information is current as of really this morning. So on to the agenda. We're going to start with some history and a brief overview of MHPAEA, and then we're going to discuss the newer comparative analysis requirement and some associated pending proposed rules with those. Then look at some recent enforcement trends at the federal level, and we'll touch briefly on participant lawsuits, what those look like and what they can mean. Then we're going to get into 6 common questions that we've been receiving about MHPAEA, and we're going to share some hopefully insights that you find practical. And we're going to end with a few compliance takeaways. So let's dive right in. Sharon, can you kick us off with some history on MHPAEA?
You know I can. That's my favorite topic.
Our historian.
So, yeah, there's a lot of reasons for that. But today I want to start us off by defining this word parity. According to dictionary.com, the authority on all words, parity means equality as in amount, status, or character. And that's really what we're looking at when we're thinking about mental health parity. So prior to any kind of mental health parity law, like way back in the early 90s and earlier, behavioral health care was often covered at lower levels or not at all. There were a lot of times a higher financial requirement like copays and coinsurance and deductibles, and there were more stringent treatment limits as to things like number of visits and inpatient days. So in 1996, as part of a reaction to Bill Clinton not being able to pass healthcare reform, Congress enacted the first mental health parity law, and it really is an issue that has bipartisan support. But at that time, the goal was to address disparities in mental health and medical surgical coverage within group health plans and health insurance offerings. And the aim of that law was to ensure that annual and lifetime dollar limits on mental health benefits were no lower or no more stringent than those for medical and surgical benefits. And for this first law, really, it was considered to be fairly watered down. Like it really didn't get to the crux of the issue for mental health benefits. And plans would get around this annual and lifetime dollar limit mandate by imposing visit or day limits, which was essentially, could be an annual limit. And the agencies were having a hard time enforcing it. And as behavioral health issues started to take more focus in our world, Many in Congress wanted a more comprehensive law. And in the meantime, also, we had states that were starting to pass their own mental health parity laws, and there was like this big disconnect between a self-funded plan and an insured plan. So in 2008, Congress passed this law that we're going to talk about today, MHPAEA, which enhanced the original law and included treatment for substance abuse disorders. And then as in 2010, as part of the ACA, the law was expanded to include not only group health plans and group health insurance coverage, but also individual health insurance coverage. So MHPAEA doesn't require a group health plan to offer mental health benefits, but what it does do is it says if the group health plan offers mental health benefits, the coverage at the very least has to be equivalent, again, our definition of a parity, which is the same as in amount or status or character, to the medical surgical benefits that are offered under the plan. And the law provides parity in 3 areas. It's this annual and lifetime limit that the original law covered, and that means that group health plans that apply an annual or lifetime dollar limit for medical or surgical benefits must generally apply those to the same way or higher for the dollar limits for mental health benefits and substance use disorder benefits. To a large degree, the prohibition on lifetime and annual limits in terms of essential health benefits under the ACA, that requirement greatly reduces the instances in which this is an issue. And so generally, this is no longer an issue. The law also requires parity as to financial requirements and quantitative treatment limits. Plans that also provide parity, so plans must provide parity between medical surgical benefits and mental health and substance use disorder benefits as to financial requirements. These are things like the deductible, copay, coinsurance, out-of-pocket maxes, and quantitative treatment limits, such as the number of treatments that can be performed, visits, or days of coverage. A plan can't have a separate cost-sharing requirement that applies only to mental health or substance use disorder benefits. And if you are new to the mental health parity game, you can see that the kinds of provisions that used to be in place before these laws were enacted they were playing lots of games. So these laws are here to sort of tamp down those issues. And now finally, the law requires parity as to a non-quantitative treatment limit. And this is what we're really going to be talking about today. This is sort of the crux of the issue. And we're going to go through those, some of the issues that you might face and the requirements. But generally, this is a limitation on benefits that is not quantifiable. So if it's not one of the other two, then it's a non-quantitative treatment limit. So MHPAEA is overseen by the Department of Labor, the IRS, and HHS. The DOL and the IRS handle private plans, and the law does not provide an independent right of enforcement by the agencies. But if the plan is subject to ERISA, the remedies under ERISA are available to the Department of Labor, and the IRS can impose excise taxes for a group health plan's failure to comply with MHPAEA. And this would involve filing of a Form 8928 for an excise tax. HHS enforces mental health parity for state and municipal plans, and lawsuits can also be brought by individuals under ERISA. And Sarah's going to talk about some of those today. Generally, these lawsuits relate to the denial of benefits for mental health treatment. And some of the lawsuits could be either from a participant or a beneficiary, and usually they're focused on recovering benefits that would have been due to them under the terms of the plan. And as I alluded to earlier, there are a variety of state laws that apply to fully insured policies that are written in that state. So who must comply with MHPAEA? Both group health plans and health insurance issuers, that's insurers, must comply with the mental health parity rules. So it applies to fully insured and self-insured group health plans, and it also applies in the individual market. What does this mean for TPAs of a self-insured plan? Well, it's the group health plan that is subject to the law. So the TPA, the third-party administrator of the self-insured plan, is not directly subject to MHPAEA, which can be a little problematic because generally it's the TPA that is administering the plan, but the employer or the group health plan is going to be on the hook. If the TPA has taken on fiduciary duty, that's a little bit of a different story, and then the parity law would indirectly apply to the TPA. There is no exemption for church plans or non-federal governmental plans. They have to comply with this law, and generally most employers, those with small employers, those with 50 or fewer are indirectly subject to the mental health parity provisions. If the small employer provides a health coverage plan that is provided through a group policy that's purchased in the small group market, that policy is ultimately required to comply with mental health parity. So if you have a small self-insured, a small employer that has a self-insured medical plan, then that employer might escape the federal mental health parity requirement, but it is possible there could be a state law requirement for those plans. So what does parity mean? And here we're going to really dive into these non-quantitative treatment limits. And again, these non-quantitative treatment limits, or NQTLs, are those non-numerical limits on the scope or duration of benefits. So it's anything that's not, has a number associated with it. And these are things that are sort of the touchy-feely part of group health plans. They are not necessarily easily measured. Examples would be medical management standards, prescription drug formulary designs, prior authorization requirements, things like step therapy or fail first policies, limits on access to out-of-network providers. And the law requires that these limits not be more restrictive than limits that are applied to medical surgical benefits. So to the extent that NQTLs do apply to mental health and substance use disorder benefits, plans and insurers are required to perform what Sarah's going to detail us about, a comparative analysis, which will document that the limits comply with the law. Again, what is parity in terms of non-quantitative treatment limits? It's not that a plan cannot have, I'm using a double negative here. A plan can have non-quantitative treatment limits, but it's how it applies to mental health and substance use benefits that might be impermissible. So if you were to separate out mental health benefits and just provide treatment limits to those benefits, that would be impermissible under the mental health parity law. So the idea is that under the terms of a plan, as it is written and operated, any process, strategy, evidentiary standard that is used to apply a non-qualitative treatment limit to mental health or substance use disorder benefits has to be comparable to and applied no more stringently than the process, strategy, evidentiary standard that is used in applying the limitation to a medical surgical benefit. So it's important to understand that if a plan has an NQTL, the plan has reasonable processes in place so that it can provide evidence as to why the NQTL might be medically appropriate and not disparate from the standard that is applied to a medical surgical limitation. Basically, the plan needs to use evidentiary standards that are set by medical experts with appropriate amount of training to determine whether a treatment is medically appropriate and what limitation might apply to it. There are definitely occasions where the clinically appropriate standard of care for a mental health condition will differ from a medical condition. So in terms of visits or days of care, it's not necessarily an apples to apples standard, but in terms of setting that treatment, the question is, does the plan rely on criteria from similar sources when looking at mental health and medical benefits? What's the rationale for the limit? How was it implemented? And what evidence did the plan rely on? So the proposed regulation, the Department of Labor provides some examples of health plan provisions that, absent similar restrictions on the medical surgical side, could constitute impermissible limitations on mental health and substance use disorder benefits. And I would just note here that this list that the Department of Labor, in the Department of Labor guidance, the DOL proposed regs, is not exhaustive. They make very clear it's not exhaustive, that it's just illustrative of some problematic examples. And again, we're going to walk through these examples, but I want to reiterate that these are, we call them red flags. And in this term red flag, we don't mean it's automatically impermissible, but these are areas, if you have any of these provisions, that you need to look at closer to make sure that there's no impermissible limitation and that the limitation as it is justified. And so let's look at our first one. This is additional or stricter prior authorization on mental health substance use disorder treatment. So this might be where a plan is going to withhold coverage for a certain treatment or therapy until it's pre-approved or approved by the group health plan. And a red flag here would be if this kind of pre-authorization is only required for mental health benefits and not for other medical benefits. Additional or stricter standards or practices for continuing mental health or substance use treatment. For example, if physician notes are required or physician justification for covering ongoing treatment of a certain condition, that could raise a red flag. Stricter standards for mental health substance use provider admission to a network, including reimbursements rates. For example, arbitrarily limiting the number of mental health clinicians in a network. This kind of provision ultimately might limit mental health coverage generally under the plan. Restrictions on telehealth visits if they're only applied to mental health conditions. Refusal to pay higher cost therapies until it's shown that a lower cost therapy is not effective. So this is where, for example, a patient might have to try certain medications, like a certain line of medications, before they can move to another tier or other therapies. Now, this may be justified for both medical and mental health treatments, but the plan, again, has to have protocols in place to show that they've done this sort of analysis. Exclusion for certain mental health treatments like ABA therapy and wilderness programs, exclusion for mental health diagnosis, for example, nutritional counseling for no nutritional counseling for eating disorders, but they wouldn't place a limit on nutritional counseling for diabetic management, that kind of thing. Restrictions on geographic location, licensing, or accreditation. Something that might be problematic would be where the plan requires that a mental health clinician have a certain degree or accreditation that wouldn't be equivalent in the medical surgical world. So it's these kinds of things, and I think we're going to get into more as we go on with our discussion today. I also want to mention that we have a copy of our a sample here, sampling of our publication. It's a red flag publication, and it would help with identifying NQTLs when you're looking at your plans. And your broker would have a copy if you would like a copy of that. And I'm going to turn it over to Sarah, who's going to take us through some of the more detailed analysis of NQTL.
Yeah, thanks, Sharon. I think it's helpful here to see that these NQTLs, they take all sorts of forms, and they can be really difficult to first identify and spot before you even get to the point where you're comparing for, compliance. So that's really where the agencies have struggled, and I think everyone in the industry has struggled for a long time. So we've had this law in place since 2008. It was in place for 15 years, and then here comes the comparative analysis requirement in early 2021. Can you go to the next slide? And I think that the comparative analysis requirement was really just a reflection of the difficulty that the departments have had in achieving compliance on those NQTLs, right? The quantitative treatment limitations, they're not perfect, but I think we've seen plans achieve compliance on the quantitative side more easily, just because they are objective and they're they are easier to identify and then assess for parity, but the NQTLs, not so much. So we have the 2021 Consolidated Appropriations Act. It introduced this new requirement for health plans and insurers to actually document NQTL compliance. And it was effective way back in February 2021. There it is there written on the scroll. Basically, this comparative analysis is about identifying each mental health NQTL and then justifying its inclusion. So justifying by showing that it's somehow comparable to the medical surgical coverage terms through what they're requiring is a detailed and reasoned analysis. And there's a lot of confusion as to what that actually means, but it's required. And so plans and insurers, they don't have to submit the comparative analysis, but they do have to have it on hand ready to provide to a federal or state agency or plan participant when they request it. So next slide, please. We're going to address just a few basic questions before we go on about the comparative analysis requirement. Basically the who, the how, and the when. First, for the who is responsible to comply? Now, there's a distinction in responsibility for the comparative analysis based on whether the plan is fully insured or self-insured. For a fully insured plan, the plan sponsor, so the employer, and the insurer share responsibility. So the insurer, the carrier, is responsible for the comparative analysis. But for a self-insured plan, the plan sponsor, again, an employer, is fully responsible under the law. The TPA, who may, design the plan, administer the claims, is not responsible for the comparative analysis under MHPAEA. So the next question, how to comply, kind of follows from that. Fully insured plans, they should confirm with their carrier that the analysis has been completed and ask for a copy. Keep a copy on hand. I think it's also a good idea for fully insured plans to ask their insurer whether their comparative analysis has been found to be insufficient through the DOL or through state investigation, and then ask what corrective actions have been taken, just to know that the carrier is on top of those things and taking MHPAEA compliance seriously. Now, for self-insured plans, as I alluded to before, they need to work with their TPAs to complete the comparative analysis. This is because the TPAs, they administer the plans, they design the plans, they have all the information on how the coverage terms and guidelines were created, but they're not responsible under the law for the analysis. And so when we get to the questions in a little bit, we're going to discuss potential strategy around this, right? How to work with your TPA to get in towards compliance, get into compliance without having the TPA be directly responsible and without a plan sponsor having all the information that they need. As to when, there's no requirement to routinely submit the comparative analysis like many of our other compliance requirements that we have for group health plans. Think of it more of a general plan document that plans and insurers have to have it on hand to quickly reply to requests from an agency or a participant. What we've heard is that the agencies, when they request these comparative analysis, they expect that they're produced within days, not weeks. So then once it's reviewed, if the DOL finds a problem on their initial review, then a plan has 45 days to respond with either a better analysis or describe how they're going to correct that issue. And then if it's not resolved, they have to notify all enrollees of non-compliance within 7 days. So that sort of declaration really opens the door, I think, to lawsuits for anyone who is denied a claim as a result of some impermissible NQTL. So that's how that last requirement has some teeth. We can go to the next slide. Okay, so we've got the CAA 2021 that introduced this comparative analysis requirement back in the beginning of 2021. And then after the first couple of years, the departments were requesting these comparative analysis from certain plans, a couple dozen plans, and they found that none of them were sufficient. So they came up with these new rules that were proposed in July 2023, last summer, and they were intended to provide more consistency and clarity on what's expected in a comparative analysis. There was also this overall theme of improving access in the proposed rules, like the departments see certain NQTLs as barriers to mental health treatment, and they see the comparative analysis as a tool available to them to address the access problem by requiring that plans document their compliance with MHPAEA. So a few highlights of the proposed rules, and you can see on the bottom of that slide, which we will send along in a follow-up email. There's a link to our Compliance Corner article that kind of goes through in quite a bit more detail, but I'm just going to hit the high points here. So in large part, the proposed rules, they map out this, what I like to call a multi-step dance to justify each NQTL on mental health benefits, right? And so that's pretty specific. It's not just, we use all of these guidelines to create our utilization reviews. It's you have to identify each NQTL and each benefit. It's quite burdensome. Along with that dance, there's this sort of bypass option that the rules describe based on, for any NQTL that's based on what they call independent professional medical standards or standards related to fraud, waste, and abuse. What's strange, though, is that the proposed rules, they didn't define these standards, like which medical standards would be acceptable, which utilization review standard would be acceptable. We don't really know. So I hope that whatever happens with the proposed rules and in some additional guidance, we'll get a bit more clarity on that, and even for them to call out a certain set of rules that would be acceptable, set of standards that would be acceptable. The proposed rules also add a meaningful benefits requirement where the plan must provide a full range of treatments for mental health conditions. So an example that they use is that it would be a problem to exclude applied behavioral analysis therapy for autism because that's a primary treatment for that condition. The proposed rules also included some network adequacy requirements for plans and insurers to collect data and then demonstrate compliance related to how the provider networks are made up. And so we may see that become a new requirement. And then one last highlight on the proposed rules, they include this new requirement for a named ERISA plan fiduciary to actually certify, like sign off on the comparative analysis. So this is pretty significant considering we don't have a clear model of a sufficient comparative analysis yet from the DOL. And it sort of feels like a difficult position for plan sponsors to be in. It also feels unnecessary in a way, right? Like regardless of whether this fiduciary sign-off is included in the final rules, plan sponsors as fiduciaries under ERISA are responsible for their plan's compliance with the law. So we'll see what happens with that specific proposal. And then after they proposed these rules, they received some really significant feedback during the comment period on different aspects of the rules and the compliance challenges. And it's unclear how the final rules are going to differ from the proposed rules. They're still pending now, and we're going to discuss the status a bit more when we get into the questions, but just remember that regardless of the status of these rules, the comparative analysis requirement from the CAA 2021 predates these rules. So even though these new rules are pending, the comparative analysis requirement is in force. These proposed rules just introduce some additional requirements and some more detail. We can move on to enforcement activity. So the DOL has said again and again that MHPAEA is a top enforcement priority, and they've proven it by putting additional resources behind their MHPAEA investigating division, namely by hiring more investigators to look at these MHPAEA issues and plans. And then in July 2023, along with the proposed rules, we got a report to Congress and an enforcement fact sheet. It identified common failures that the departments were seeing. Overall, a lack of required detail in the analysis. For each NQTL that's applied more stringently on the mental health side, they're really looking for a meaningful demonstration of compliance, how there's some specific non-discriminatory justification for covering mental health benefits in less favorable terms. Like, for example, if a plan excludes a certain mental health benefit, then the DOL is expecting the plan to identify something like a specific standard of care guidelines that support that exclusion on medical grounds, rather than just citing generically, we rely on industry publications or medical journals. I think the DOL is really expecting which ones, which industry publications, what's the medical evidence that you're relying on. The report also describes some corrective actions taken by plans. So typical corrective action would be to remove the NQTL or limit its scope, to add an excluded benefit, to go back and pay claims that were wrongfully denied because of the NQTL, or just to work with a plan to submit a complete and detailed comparative analysis. Quick note on the legislative recommendations. So in the last two reports to Congress, the departments noted an aspect of the law that makes it really difficult to enforce MHPAEA efficiently. That's the inability to enforce the law directly against a TPA, right? We've talked about this. So the TPAs design and they implement the coverage limitations. Plan sponsors typically just adopt those limitations in a standard plan design. And right now, the agencies need to address any issues in those designs against a self-insured plan and then pull in a TPA if they are named as a plan fiduciary, meaning they need to go plan by plan. But because TPA plan designs are typically standard, it would be much more efficient to investigate MHPAEA compliance with the TPA directly and then just require global correction across all those plan models rather than having to go plan by plan. But this would require an act of Congress because it's not in the original MHPAEA statute. TPAs just aren't directly subject to the law. So this is something that they asked for in this latest report. So if we can go to the next slide. Yeah, so the report also called out a handful of priority enforcement NQTLs. Some of them are listed there, and Sharon discussed them earlier, but they really reflect the department's concern about NQTLs that restrict access to treatment, right? So if you have more or stricter prior authorization requirements or more frequent continuing care coverage reviews, that means your claim's more likely to be denied or that your coverage is more likely to be delayed. It's a barrier to treatment, right? It's an access issue. They also talked about two new focus areas, and this again was in the report to Congress, not the proposed rules, but they talked about two new focus areas that actually mirror those proposed rules, meaningful benefits requirements that I mentioned. That is excluding ABA therapy to treat autism spectrum disorder or excluding nutritional counseling for eating disorders. So they've called those out as particular areas that they're looking at. So if we can just go to the next slide, and I'm going to take a minute to talk about participant lawsuits. Thank you. So when we talk about legal risk under MHPAEA, it's not just from a federal agency investigation. It's also risk from participant lawsuits. So arguably, this is a higher risk because federal agencies have limited resources, and there are a lot of plan participants out there. These participant lawsuits are brought under ERISA appealing a claim denial and then alleging a MHPAEA violation. So as Sharon said earlier, the cases are typically challenging like a medical necessity criteria or a coverage exclusion as a MHPAEA violation. The defendants it's going to be, the ERISA claim fiduciaries, so an insurer, a TPA, a self-insured employer. These cases don't appear out of thin air. They need to be based on a claim denial. So I always like to say that it's important to pay attention to participant complaints because I think that they are a good signal that the participant may be complaining to the DOL or filing a lawsuit and that it's time to get legal counsel involved as early as possible and look for a resolution. Perhaps there's some sort of MHPAEA violation to correct and it can be resolved early on. Okay, so that's it for background. Let's get into some common questions that we've been getting on MHPAEA. So the first one, this is one that we've been asking ourselves. When will the proposed rules be finalized? Sharon, your thoughts on this?
So I think you and I had thought we would see them by now, right? We had news that they went to OMB for approval in July, at the beginning of July, sorry. And now they seem to be in this holding pattern. And we did do a little bit of research to try to figure out what the heck is going on. And last spring, the White House released this effort that they're making to have transparency in the regulatory area, and an effort is to get as much as possible input from the public. They announced that the agencies would be holding these listening sessions. And this a listening session is generally, a meeting where the agencies make themselves available at a certain date and time, and then different stakeholders or interested parties can talk to the agencies about their concern. So even though this proposed reg has gone through its formal period of comment, and they've clearly drafted a final reg because we've seen that it's been submitted. They have been holding, the IRS and the DOL and HHS has been holding listening sessions. And we can see those sessions, on the record of what's happening there. And there is, in fact, one that is happening on the 22nd of this month. And so in light of that, it's really hard to imagine when the reg is going to be finalized. And in light of the number of listening sessions that have been happening for the last since July, I think. It is not clear, are the agencies going to pull back that reg and address some of those issues? During those sessions, it's really just sort of there's very little interaction with the agency. It's more like a venting session. So stakeholders would just sort of say what they think some of the issues are, their problems are, what they're worried about, and you don't get feedback really from the agencies. So at this point, we just don't know. We don't know if they're going to finalize it and the reg could come out at the end of September, or if they're going to pull it back. And I think we have to sort of wait and see. If we see more listening sessions, I would take the bet that it will be postponed even further. But we say this today, Sarah, and tomorrow we could have a final reg.
Right.
And I don't think so. I don't think we're getting a final reg till after the 22nd.
Yeah, I'm not a betting woman, so I'm not going to place any bets on this. But so Sharon, there was recently a Supreme Court decision, right? So Loper-Bright.
Yes.
That seemingly really cut back federal agency authority.
Yes.
Would that impact these regulations?
So, I mean, that is something that that I have been thinking about. So for this Supreme Court decision, there was this Supreme Court decision overturned another one, Chevron. And Chevron said where there's ambiguity in a law or where things are left unanswered, that the agencies have the ability to answer those questions through regulations, and that courts need to give deference to how the agency interprets the statute. So this latest decision overturned that. And so now either Congress has to give explicit authority in a law to the agency for very explicit components of that law, or the agency needs to provide justification from what they've got in the law as to why they are regulating a certain area or providing rules in a certain way. And so one of the thoughts that I had was, will they, based on these listening sessions, pull the reg back to try to beef it up to justify why they've made certain decisions and not others. So I do think that is a reality. I'm not sure how quickly we're going to get the reg. I could be proved wrong. I don't know.
And then once it is finalized, if it is finalized, we could expect a lawsuit, right?
Yes, we can expect litigation challenging, especially where, there's one might find something overburdensome. Yep.
Yep.
Yeah.
Okay, let's move on to the next question.
Does not want to cooperate. Here we go. So, Sarah, can a self-insured plan rely on their TPA to complete the comparative analysis?
I'm so glad you asked me this question because it's a common question and it's a difficult to answer. So the answer is no. And that's because self-insured plan sponsors hold full responsibility for the comparative analysis, right, under MHPAEA. It ties into ERISA's fiduciary duty requirements. They have a fiduciary duty to monitor the TPA's claims process, but then they also have responsibility to complete the comparative analysis. But requesting the TPA's analysis is a really good place to start. It's often based on their insured model, which mirrors their self-insured model. But it's definitely a good starting place. It's not the last step, though. There are additional steps. The next step would be to review it with legal counsel to see if it's sufficient. Asking, is it detailed? Is it reasoned? Is it like overly broad? Is it complete? Are there parts of the plan that's missing? And then another important step is to look at the plan document, right? So as we've discussed, like these red flag and QTLs, and we have that list that you pointed out to help with that step. If there are any red flags, like let's say an exclusion, the next step would be to press the TPA for a detailed and reasoned comparative analysis on that, or just remove it, right? Like you either justify it in a detailed and reasoned way, or you remove it.
Yep.
It's also important to confirm that the agreement with the TPA actually addresses MHPAEA compliance, because this is not going away, and there's a need for continued cooperation between self-insured plans and TPAs. So that the agreement should say that they're going to provide a comparative analysis, they're going to help respond to any agency request or participant request. I did see we got a question in the chat about how long the comparative analysis is good for. Like if you get it done, like when's the next time you have to redo it? It's not, again, it's not like a strict annual requirement like many of our other compliance requirements. So it's more a matter of when your plan changes, like if you add an exclusion to a new mental health benefit, if you shift the prior authorization guidelines, then you would have to redo the analysis on those changes.
Yeah. And what are your views on outside vendors completing the comparative analysis on some of these vendors?
Yeah, sure. So this is tricky. We don't know on our benefits compliance team of any vendor actually performing what we consider to be a full comparative analysis. It's
Mhm.
rather more like that second bullet there, like a red flag and QTL review. So it's helpful, but it's not the full comparative analysis as we understand it. The other issue is that the DOL hasn't said yet that they've received a sufficient comparative analysis, and they haven't provided a clear model of what they consider to be sufficient and sufficiently detailed and reasoned. Like, what is that? So I'd say that a vendor in this space can definitely be helpful, but it's not a complete solution. Self-insured plan sponsors need to look at any problematic NQTLs and take steps to address them, right? That's really the most important thing the DOL is looking for, to identify these problems and then justify them or just remove them.
So it would be one step in a little bit of a bigger process.
Correct. Yep.
Okay.
So next question, telehealth, very popular benefit these days. So the question is, we are about to engage a telehealth vendor to offer mental health therapy to our employees and their families. Because there will be different mental health benefits versus medical benefits, does this violate MHPAEA?
Yeah. So the short answer is no. And one point before we get into why it's not a problem, is that telehealth in and of itself, this telehealth that they're describing here is providing medical benefits. So just want to say right up front that this type of program should be integrated with the group health plan so that it complies with the ACA. And then all the benefits would be tested together. And so I think, as we mentioned before, mental health parity is sort of the limit for what can be done. And it is certainly okay to provide better mental health benefits than medical surgical benefits, for example. And so in this case, the plan could be more generous in its mental health substance use disorder benefit than it is in the medical surgical. So if they wanted to provide telehealth only for mental health benefits and not for medical surgical, they could go ahead and do that.
Great. We're talking about telehealth, and we'd be remiss to not mention the temporary allowance, right? The temporary telehealth relief for HCHPs to provide telehealth services prior to the deductible without negatively impacting HSA eligibility. That's only for plan years through 2024. The relief hasn't been extended further yet. I think that there's possibly some bipartisan support for an extension, but it may come through legislation that's passed very late in the year, like end of the year, late December
The
budget bill,
right?
or not at all. So we just raise that to say, like, if you have that as part of your benefits now, be prepared for that relief to end.
Yes, wait, we're on the edge of our seats.
On all of these issues. Fun place to be.
So many things.
Yes. Okay.
So our plans, TPA contacted us recently about removing an exclusion for nutritional counseling for eating disorders in the plan. What does this mean for our plan?
Yeah, so this is a pretty clear red flag. We know the DOL is targeting this NQTL. They said that they are. So that's the first thing. And then secondly, the fact that the TPA has reached out about something specific in the plans is suspect. It means either the DOL has contacted them about it, or they've done the comparative analysis and they can't justify it themselves. So we're talking about pretty high risk NQTL. And if your plan that wants to exclude nutritional counseling, then you should review the risk with your legal counsel. The basic question is, whether nutritional counseling is excluded on the medical side too, and then also what are the reasons for excluding it. But this is something that definitely should be considered high risk and time to look at closely with legal counsel.
Yep. Okay.
So next question is, we have an employee whose child's claim for a wilderness program was denied as excluded under our plan. Is this an impermissible NQTL?
Yeah, so the answer is possibly. This is a red flag issue. But remember, that doesn't necessarily mean that it's automatically an impermissible provision. wilderness treatment exclusions are pretty common in group health plans. And one of the problems is that wilderness treatment is not necessarily a defined term, right? It can mean a lot of different things. It could be camp, for example. There may not be a medically appropriate, certified experts that are staffing the program. And the program might not even be therapy. So let's break apart like the analysis here. So if we look at first, like just a blanket exclusion for all wilderness programs, that could be a little problematic. So is the plan excluding a treatment or a therapy that otherwise would have been covered under the plan, except that it's happening outside?
Right.
Right. And if the answer is yes to that, and there's no other exclusion like that for medical benefits, then this could be a problem, right? So and so it requires a closer look. And so the second issue around this is, what is the treatment that's actually being provided by this particular program? Is it considered residential treatment? And if so, what's the justification for the exclusion if otherwise residential treatment would be covered, because it needs to be covered under the plan. And so I think this is just an issue that needs a little extra scrutiny in the plan. And is there something similar that's happening on the medical surgical side? And if not, why not?
Right.
And, it's okay to exclude, camps or schools that don't have clinical or a therapy component to them. But the document should state that pretty clearly, or should state that clearly. The other piece is, it may be possible to sort of break out, if the therapy is happening by a licensed provider, to break out that piece from maybe the other pieces of that program.
Right. This like catch-all term wilderness program or wilderness therapy has really, mucked up a lot of these claims. So I don't know if it's as much of a DOL enforcement priority now, but what I can say is it is a highly litigious area.
Yes.
And the courts are going through just what you just broke down, Sharon. Like, what do you mean by wilderness program? What's actually being provided? What's being excluded? Is it clear to participants? Because that's another part of this, right? Like, you need to be able to clearly tell participants in a plan what's covered and what's not covered. So all of those issues kind of come into play around these wilderness programs.
Yep. Okay, good. So we have an employee whose child was denied continued ABA therapy. They sent us a request for documents, including our plan's comparative analysis and medical necessity guidelines. Do we have to respond to that?
Yes, as I said there, thoroughly and promptly. This question, it's a nice reminder that we're not just talking about MHPAEA here. ERISA, as we've said, applies to the claims process and document requests. Yep. So it's not just the departments, right, that can request a plan's comparative analysis. Participants and beneficiaries have the right to do the same. ERISA generally allows plan fiduciaries up to 30 days to respond before potential penalties start to accrue. But then after those 30 days, it's $110 per day. So for a fully insured plan, the carrier should be handling these document requests related to any sort of claim denial or comparative analysis. There may be a need to sort of, redirect the request to the right party, but the carrier should be handling that. And then the self-insured plan side, there's a need to coordinate with TPA, but it's also a good idea to review any of these specific plan document requests with legal counsel, because they signal a potential lawsuit. So it's just good to pay attention to that and get legal counsel involved early. But yeah, there was a case that I like to use as an example. It was a medical necessity criteria challenge, and the court found that the criteria for residential treatment benefits on the mental health side violated MHPAEA because it had additional hurdles compared to the inpatient care on the medical side.
Mhm.
So they found a MHPAEA issue, but then for the ERISA penalties, they imposed over $120,000 on statutory penalties for the defendant's failure to disclose all the documents timely, right? There was 120 or 1,231 day delay. And so that led them to those penalties. So the lesson is really work with your TPA to make sure that you've got the document disclosures ready to go within 30 days.
Yep. So this is another litigious area.
Yes.
Yep. Okay. What are some takeaways for us?
So takeaways. MHPAEA is not new, as we talked about, but we do have recent guidance and we have some increased enforcement efforts. We know that it's a top DOL priority this year and likely next year too. Plans need to have the comparative analysis ready to go to demonstrate that they are meeting those NQTL requirements. And employers who are sponsoring these plans, they cannot fix these issues alone. They need to work with TPAs to figure out how to justify or remove any problematic NQTLs. Good place to start is to review your plan. What can you see? Can you see any issues in your actual plan document? And we have that red flag publication for you. So if you're a fully insured employer, communicate with your carriers on the compliance of the comparative analysis. Make sure that they have it. Make sure that you have a copy on hand. Self-insured employers, work with your TPA. Make sure it's addressed in your administrative service agreements. If you see any of these participant complaints or any other red flags, fix them. You don't want the DOL knocking on your door. You don't want a lawsuit. And then keep an eye out for new developments. As we've said, this is changing all the time. So make sure that you're paying attention to any new developments. Next slide. On that, we have Compliance Corner. Compliance Corner is our bi-weekly newsletter where we will report on any key developments on the regulations, or we also report on notable case law. So keep an eye on that. And then there again is our MHPAEA compliance red flag NQTL publication. That's just a one-pager, maybe a two-pager that will help you go through your plan and see whether there are any obvious issues there. And lastly, we've got some links to some Department of Labor resources. The first link there is it's really, I consider a great primer of Parity. So if you kind of are looking for some more background, go to that, and it answers a lot of great questions. And it's pitched towards policymakers, but I think it's a very helpful tool just to learn more about Parity. Second one, the DOL self-compliance tool. This was last updated in 2020, so before the comparative analysis, and we hope that we're going to get a new one soon, but it is still very useful to understand really what the departments are looking for as far as, figuring out whether any of these NQTLs are problematic. And then the last is a link to the DOL's news and updates page. So I think that is it. I think we answered the questions in the chat. And Sharon, any other last thoughts before we depart?
No, I think mentally I'm all done. Yeah.
Okay. Yeah, we'll keep an eye on everything. And like I said, check out to see if we have any updates in Compliance Corner for you. We'll be sure to report them when we know anything. Amber, you can take us out now.
All right. Thank you, Sharon and Sarah, for sharing your valuable time and expertise with us today. To reiterate, today's presentation was recorded. We will be sharing the recording in the follow-up email and on the NFP website. If there are any portions of this call that you missed, by Monday, you'll receive an email with a link to the full recording. The PowerPoint slides used during this presentation will be shared in the same email. At the end of this call, a survey will populate in a new window. Please take a brief moment to complete the survey, as it lets us know what topics are important to our listeners and helps make our education program as current and relevant as possible. That concludes our webinar for today. Thank you everyone for joining us, and have a great day.